Hi, this is Dr. Reynaldo Ong-Joson, Director of ROJoson PEP Talk. I have a patient empowerment program in which I like to empower the lay people or patients to take control in the management of their health. There are 3 courses in the PEP Talk. I completed the 4th course on October 9, 2021. From October 23, 2021 onwards, have been tackling health disorder and health issue courses. This may take 3 years or longer. My pep talk today is entitled Fundamentals and Generalities in the Medical Management of Breast Cancer, Part 2. This is part of the cancer course. The empowerment objective is for lay people to have an understanding of the fundamentals and generalities in the medical management of breast cancer. Some definition of terms in the title and the limitation of the coverage of my talk. Fundamentals to mean simplest and essential facts and theories which can serve as a basis or foundation and support for advanced information. Generalities to mean general statements of information, not covering specifics and not too detailed. Medical management to mean diagnosis and treatment of breast cancer, usually done by physicians. I have tackled part 1 last week. Now I'm going to tackle part 2, which consists of the following: treatment of breast cancer, surveillance of breast cancer, prognosis of breast cancer, and palliative and hospice care for breast cancer patients. Treatment for breast cancer. After formulating the pre-treatment diagnosis, including determining the extent of the breast cancer and other factors which may have an effect on the treatment, first thing to do before considering and comparing the options of treatment methods or modalities is to spell out the specific objective or goal of the treatment, whether curative or palliative. Curative goal means eradicating known tumors or cancers entirely, preventing the recurrence or spread of the primary cancer. Palliative goal means relieving symptoms after all the reasonable curative approaches have been exhausted. At the time of treatment, a patient may present in a cancer stage in which the goal is at best palliative only, meaning just relieving symptoms. These are usually the patients with advanced cancers. For patients presenting with early-stage cancers, the goal is curative. That is, eradicating the tumors or cancers entirely and preventing the recurrence or spread of the primary cancer. Thus, the objective of treatment is primarily dependent on the stage or extent of the cancer at the time of treatment. Stage and staging of cancer. This describes the extent of a cancer. There are so many ways of staging cancer. The simplest is to stage it, to classify it into early stage and advanced stage. Another way is localized, regional, and distant. Another one, localized, early locally advanced, late locally advanced, and metastasized stage. The TNM staging is another way of staging. It describes the size of the cancer and how far it has grown. As I said, the most popular staging nowadays is TNM staging, where T stands for tumor, N nodes, and metastases. In the stage 1, the cancer is usually localized. And then in stage 4, there is already distant metastases. In between the 2 stages are stage 2 and 3. There are 2 types of staging also for breast cancer. We have the so-called anatomic staging, which is the defined by the areas of the body where the breast cancer is found. This one, the TNM staging. Then prognostic staging, how likely a patient is to be cured of the cancer, assuming that all appropriate treatment is given. So this is the usual anatomic staging system for breast cancer. Stage 0, localized to milk ducts, or the so-called ductal carcinoma in situ. Then you have stage 4. There is a M, or positive for metastasis, such as bone, lungs, liver, and brain. And in between, you have 1, 2, 3, and 3. And then in stage 1, the tumor is less than 2 centimeters. There's no node. There's no distant metastasis. In stage 2, they classified it into A and B. Okay. So the presence of lymph nodes usually automatically make a stage 2. Okay. And then there's still no distant metastasis. If there's distant metastasis, automatically it's stage 4. Okay. So in this stage 2A, the size can be less than 2 centimeters or 2 to 5 centimeters. And then in 2B, the size of the tumor is more than 5 centimeters, but no nodes and no metastasis. Stage 3, which are usually called the locally advanced breast cancer, it's subclassified into A and B. In 3A, the nodes, there are plenty of nodes which are adherent to each other. The T can be of any size, but again, there's still no distant metastasis. In stage 2B, far advanced stage, but still no distant metastasis. Okay, but this time the tumor has spread to the skin, chest wall, or internal mammary lymph nodes. Prognostic staging system for breast cancer. An example is there is a prognostic grouping of information on the cancer cells using the hormonal receptor assays and the HER2 gene. Examples are ERA, PRA positive, and HER2 negative. By the way, ERA stands for estrogen receptor assay, PRA progesterone receptor assay, and HER2 is the human epidermal growth factors receptor 2. Okay, so another group of information: ERA positive, PRA negative, HER2 negative, ERA negative, PRA negative, HER2 positive. And then all the three are negative, or the so-called triple negative. Okay. So the triple negative usually carries the worst prognosis. There are a lot of cancer treatment being advocated. You have the mainstream ones and the non-mainstream ones. Mainstream ones are those accepted by and being promoted by majority of the physician cancer specialists. That's why it's also called conventional or standard. They have well-documented evidences of effectiveness in various degrees. In contrast, the non-mainstream ones are those outside the mainstream ones, so-called alternative medicine, the popular term, with health claims usually not meeting evidence-based standards. The mainstream modalities of treatment for cancer, and for breast cancer for that matter, are currently the following: surgery, which is basically the same as operation and then cutting, radiotherapy using radiation, burning, chemotherapy using drugs, killing, hormonal therapy using hormonal manipulation, and then immunotherapy, manipulation of the immune system, and then targeted therapy, gene manipulations. The commonly used non-mainstream or alternative medicine treatment for cancers are currently the following: herbs, herbal medicine, special diet, supplements, including vitamins, acupuncture, lifestyle medicine, which include healthy eating, healthy activity, and healthy behaviors without the use of medicine. By the way, alternative medicine is defined loosely as a set of products, practices, and theories that are believed and perceived by their users to have a healing effect of medicine, but whose effectiveness have not been established using scientific methods. Word of caution on the use of alternative medicine for cancer. Delaying surgery, radiation, chemotherapy, and or other traditional treatment by using alternative therapy can allow the cancer to grow and spread to other parts of the body. Evidence shows that people who use alternative therapies in place of standard cancer treatment have much higher death rates. In a study in 2017, after a median of 5 years, patients with breast and colorectal cancer were nearly 5 times as likely to die if they had used an alternative therapy as their initial treatment than if they received conventional treatment. The mainstream modalities of treatment for breast cancer can be classified into localized and systemic. Localized therapy means treatment that are directed to the specific limited area such as the breast and the armpit. So these include surgery and radiotherapy. Systemic therapies usually use drugs that spread throughout the body to treat breast cancer cells wherever they may be. They include chemotherapy, hormonal therapy, targeted therapies, and immunotherapy. Breast cancer treatment may be single or combined modalities depending on the extent and track records of effectiveness. So one may use localized therapy only, surgery, or radiotherapy, usually used for localized lesion. Systemic therapy, drugs, usually for widespread cancers. Then you can combine the two, localized plus systemic therapy. So examples are doing surgery first, then after that, chemotherapy, and then radiotherapy, or doing chemotherapy first, then surgery, then chemo, then radio. Or another combination is doing surgery followed by hormonal therapy. There are many types of operations: radiotherapy, chemotherapy, hormonal therapy, and other therapies. So any cancer treatment can be used as the primary treatment, but the most common primary cancer treatment for breast cancer is still surgery, especially those in the operable stage. Other combinations that are done can be done that depending on the anatomic stage, prognostic stage, and other factors like track records or effectiveness. So these are just some examples of the different types of operations: total mastectomy, subtotal, axillary dissection, axillary sampling. As to radiotherapy, external beam radiation therapy, brachytherapy. Chemotherapy, multiple or single, usually multiple. Then different combinations like CMF. So all of these letters stands for the name of the drugs, CAF, and taxane and docetaxel. Hormonal therapy examples are tamoxifen, letrozole, anastrozole, exemestane, and other therapies like trastuzumab and fulvestrant. After the physician has decided on the goal of treatment, he gives or lists the various options of treatment and gives data on the BRCA. With the data given, the patient is asked what he or she prefers. Example of BRCA: comparative analysis of treatment procedures. Option 1, greatest survival. Option 2, in between. 1 and 3. And then 3, the least survival rate. Acceptable risk, example. The cost, example, will be 5,000 for option 1, 6,000, and 3,000 for option 2 and 3, respectively, assuming that all are available. So the best option here is giving priority on the benefit or the goal of treatment, still greatest survival rate, and the cost is the most minimum. Surveillance of breast cancer. Surveillance after cancer treatment means monitoring for recurrence after all evident cancers are eradicated. This is usually done after a curative treatment, or monitoring for progression or regression after palliative treatment when all the evident cancers are not and cannot be eradicated totally. The questions or issues usually posed in the topic of surveillance will be by whom, how long, how often, and what methods. By whom? It can be done by oncologists or the family physician taking care of the patient. Okay. Okay. But it all depends on the patient whom they prefer in terms of competence, expertise, professionalism, holistic and compassionate care, cost, availability, convenience, etc. By the way, the oncologist is defined as MD or doctors with specialty in cancer treatment. There are various types. You have surgical oncologists, medical oncologists, radiation oncologists, and others. Okay. So you can choose one or more as indicated and as preferred, and then use the following criteria in the selection of which one that will be that you would want them to take care of you. How long? For those with curative treatment goal, it's lifetime, as all cancers have the potential to recur even after a long period of time of remission, even after 10 to 15 years. And then for those with palliative treatment goal, 1, until signs of progression and regression occur, until a call for decision for hospice care is made. That means no more aggressive anti-cancer treatment, and until the end of life. How often? 2 situations: monitoring for immediate results with treatment and monitoring for recurrence of cancer after curative treatment. So when we monitor for the results of treatment, we usually monitor the side effects and complications of treatment, and then the response to treatment, such as chemotherapy, radiotherapy. The duration of monitoring will be dependent on the types and duration of the treatment, okay, whether surgery, chemotherapy, radiotherapy, recuperation time, expected response times, so such as 2 to 3 months after the chemo, etc. And frequency of monitoring will be ranging from daily to every month, usually an average of 6 months. In the monitoring for recurrence of cancer after curative treatment, okay, it depends on the type of cancer in terms of how often, treatment done, usual prognosis, time of treatment, whether it's soon after or long after, and then the mindset and personality of the patients, etc. So the general guidelines here would be, it will be more often for those with higher risk for recurrence, such as aggressive type of cancer, early post-treatment, say 1 to 2 years when recurrence usually appears, and anxious patients who need frequent psychological support from physicians. What methods? Basically 2 methods: symptom sign directed surveillance approach and the regular screening instrumental laboratory diagnostic test directed surveillance approach. In the symptom sign directed surveillance approach, the patient's symptoms and physical physician signs findings will direct the instrumental laboratory diagnostic test to be done. Whereas in the regular screening instrumental laboratory diagnostic test directed surveillance approach, there is a battery of screening tests on possible sites of recurrence, done even in the absence of symptoms and signs. The physician gives or lists the options of surveillance and then gives data on the BRCA. With the data given, the patient is asked what or she prefers. Usually, in terms of benefit, the physicians will have to give data on, number 1, the benefit in terms of early detection, and then in terms of survival, and in terms of quality of life. An example of the data that will be given to the patient, okay, in terms of early detection, okay, comparing option 1 and 2. Option 1 is the symptom directed. Option 2 is the battery of tests directed. Okay, so with the symptom directed, the detection will be a little later compared to the battery of tests. Okay, earliest or earlier. Then in terms of survival, whether it's option 1 and 2, it's the same. Then in terms of quality of life, the quality of life is better for option 1 and poorer for option 3. And then the risk, okay. Usually in option 2, there are a lot of false positive involved. And then in terms of cost, but the battery of test-directed surveillance will cost higher. Okay. Then all of these two are available. So the patient is asked what she prefers, and then the decision will be either to do symptom-directed or battery of test-directed. Prognosis of breast cancer. Prognosis means estimating how the cancer will go for you, the likely course of cancer without treatment, and with treatment, whether curative or palliative, what is the likely outcome? What are the chances of recovery from cancer? What are the chances of response to treatment in terms of cure, remission, or recurrence? And then usually when you talk about prognosis, usually there's an estimate of 5 to 10 year survival rate, and then the giving of information on the median survival rate. The prognosis of breast cancer will be dependent on the type of cancer, stage of cancer, inherent biologic behavior of the cancer, with or without comorbidities such as other illnesses, and the gravity of the comorbidities, and the track records of the breast cancer. Track records of cancers usually is in terms of 5 to 10 year survival rate and the median survival rate of the different cancers. Okay. And this is usually divided into two. Okay. 5 to 10 year survival rate by stage of cancer, or with and without treatment. 5 to 10 year survival rates of cancer. This is the percentage of patients who are still alive 5 or 10 years after they were diagnosed or started treatment. So this is an example. Stage 0, close to 100% 5-year survival rate. Practically all are still alive after 5 years. Stage 1, 98%. Stage 2, 93%. Stage 3, 72%. And then stage 4, 22%. And this is an example of a table showing 5 years, 10 years, and even 15 years survival rate. These are the data that are published and that can be used for decision making. Median survival of cancers means the length of time from either the date of diagnosis and start of treatment for a cancer that half or 50% diagnosed with the cancer are still alive. So they're usually computed in terms of months, sometimes years, okay? And then they classify the data into median survival rate without treatment or with treatment, and median survival rate or time based on the stage and based on the type of metastasis. So the median survival rate in breast cancer, stage 4, okay, is about 3 years or 26 months. And the 5-year survival rate is 20%. And then the median survival rate range from 8 months for patients with brain metastases to 36 months for patients with bone metastases. Okay. So those with bone metastases usually live longer. Okay. This is a anecdotal reports, okay, that will show you that the prognosis of a patient or the survival rate of a patient the median survival will vary from person to person. So this is a news item which I got recently. Stage 4, Kim Green has lived with metastatic breast cancer for the past 19 years. A two-time cancer survivor became the oldest living American. Delma Sutcliffe turned 114 years old in October. She holds now the record as the oldest living American, as the previous record holder died recently at age 116. Sutcliffe has survived breast cancer twice during her lifetime. She was born in Lancaster County, South Carolina in 1905 when Teddy Roosevelt was president, and now resides in Omaha, Nebraska. The last topic is palliative and hospice care for breast cancer. There are two terms that one will encounter in the medical management of cancer patients, which most Filipino lay people are not familiar with, and which most Filipino physicians do not acquaint their cancer patients with: palliative care and hospice care. Palliative and hospice care are being used in patients with advanced cancer, patients who have little or no prospect of cure and who are expected to die, and for whom the primary goal is to optimize the quality of life in the remaining years of their time on Earth. Both palliative and hospice care provide comfort for the cancer patients in terms of physical, mental, and spiritual comfort. Palliative care can begin at diagnosis at the same time as the treatment, so it may consist of anti-cancer treatment. Hospice care begins after treatment of the cancer is stopped, so no more anti-cancer treatment when it is clear that the person is not going to survive the cancer. Okay. So this shows advanced cancer. Okay, the goal is palliative. So palliative care is started. Then after a while, if there's no more chance, small chance for cure for surviving the cancer, then hospice care takes over. Summary and takeaway. I have discussed the treatment of breast cancer, surveillance of breast cancer, prognosis of breast cancer, palliative and hospice care for breast cancer patients. Takeaway in relation to patient empowerment. Be always in touch with reliable medical information on fundamentals and generalities in medical management of breast cancer. Remember that knowledge is power, it gives power. Use the 4 Ks of patient empowerment: kaalaman, kakayanan, karapatan, and kapangyarihan to gain greater control over decisions in the medical management of breast cancer. So with that, I end my pep talk today, Fundamentals and Generalities in Medical Management of Breast Cancer, Part 2. I hope I have enlightened you to have a better understanding of the fundamentals and generalities of medical management of breast cancer. Thank you and good day. Mabuhay kayong lahat.